Hi kids! So as promised, I will be discussing to you your other electrolytes, those electrolytes remaining, the one that I have presented in your introduction. Everything there will be discussed, so we are done with your sodium and potassium, so we'll continue on with the rest of the electrolytes. So forgive me if I sound like this and if I tend to sniffle a lot. Kasi kids, I am actually not feeling well. But then again, I don't want to delay the sending of this video lecture to you so that you would have enough time to study also this topic since we will be having a quiz about this one on Monday. So without further ado, let me continue. So this will be our objective. So as usual, we'll begin with the general properties of your specific electrolytes, then their sample considerations, their determination or methods, and the reference range. So these are all the other electrolytes that will be discussed in this video, starting from your chloride, then your calcium, then your magnesium, then your bicarbonate, then your phosphate, and lastly your lactate. Now I actually added one last thing, which is about your anion gap, which is very important. And although there are a lot of electrolytes that will be presented here in this video lecture, then again, most of the electrolytes here have only a very short or ano lang, yung tipong mabilang lang ang number of methods that will be discussed. So let us begin now with your chloride. So as you can see, chloride is a major extracellular anion and that it functions in the following. So it actually is involved in maintaining your osmolality along with your sodium. It also maintains your blood volume and even your electric neutrality. Now, chloride shifts secondarily to a movement of your sodium or your bicarbonate ions. Now, in terms of function, as mentioned by Bishop, chloride's function is not really well understood. But then again, one thing that we can look at the importance of your chloride is in terms of maintaining osmolality and its electric neutrality. Because kids, chloride actually provides electroneutrality, especially in terms of your sodium. Because, diba, sodium is your major extracellular cation, while your chloride is the anion one. So every time that there is sodium being transported from one place to another or being shift from one place to another, chloride will actually follow. Chloride, chloride will actually follow, maintaining this what we call electric neutrality. Kasi siya yung negative and then si sodium yung positive. So actually, chloride's transport is generally passive, kids, and it always follows the active transport of your sodium. So for the specimen consideration, serum or plasma can be used for your chloride. And if you tend to use plasma, then your heparin will be your best anticoagulant for that. Now, specifically yung lithium heparin nyo. Actually, in the electrolyte testing kids, yung anticoagulant of choice talaga natin would be your lithium heparin or heparin in general because as stated by, I think si Bishop pa rin, heparin compared to your other anticoagulants, siya yung may minimal na chelating properties, siya yung may minimal effects sa mga shift sa water, and siya din po yung may relatively low na cation concentration. And if you could still recall, regarding the discussion of your different anticoagulants, diba there are actually two possible types of heparin placed in your evacuated tube. You have your lithium heparin and you also have your sodium heparin. So, syempre, being your sodium, being a specific electrolyte, it would be best not to use that one as it may affect your testing. So that is why your anticoagulant of choice should be the lithium one. Other specimens actually that can be used for chloride kids, you can actually also use your whole blood sample, but that depends on the analyzers that will be used. There are analyzers that will allow you to make use of whole blood samples, In terms of urine, pwede rin po yung urine analysis. Just make sure na 24-hour urine collection po siya to better estimate and kumbaga to take also consideration sa mga possible na variations or fluctuations on the certain substance or analyte that we are trying to measure. And then lastly, sweat can also be used as a specimen for chloride testing, especially if we are trying to look into the disease called your cystic fibrosis. So may tinatawag po tayo na sweat chloride test, which is diagnostic of your cystic fibrosis. So literal po na yung sample nyo is yung sweat, and just a general lang din na description or with regards to your cystic fibrosis kids is the kind or is a condition in which yung affected po is all of the organs in our body that produces mucus. So basically affected si lungs, so yung mga ganun yun na part. So hemolysis does not cause a significant change in your serum or plasma values. However, with marked hemolysis, levels may be decreased as a result of a dilutional effect. So as usual, kids in general, di po pwede si hemolyze sa sample, so might as well do repeat collection if that's the case. So for the determination, you have your ion selective electrode, your ISE, and you have your amperometric colorimetric titration. So for your ISE, syempre, di ba, naatay mga ion exchange membranes, naatay mga electrolytes, and the specific ion exchange membrane that is used for chloride determination, kids, is what we call your tri-N-octyl propyl ammonium chloride decanol. And then for your amperometric colorimetric titration, which is also known as your cut-love chloridometer. Now, this test, kids, this method uses generation of your silver ions, as seen here in your chemical reaction. There is use of your silver ions here, which will combine with your chloride in order to quantitate your chloride concentration. So, kumbaga, what happens here, kids, is that upon the addition of your silver, it will saturate, it will try to combine to all of the chloride present in the sample. And then once saturate na lahat ng chloride, syempre you would expect na may mga excess or free silver that will be present in the sample, and that excess or free silver, kids, would already signify that it is already the endpoint of your titration. Kumbaga, excess or free silver is your will indicate na all of your chloride has already been saturated, and the elapsed time, kung gaano katagal yung pag-saturate kay chloride, that would be directly proportional to the concentration of chloride in your sample. So, yun po yung cut-love chloridometer. So, other test pa would be your mercurymetric titration, also known as your Shales and Shales method. Now, here, we need a protein-free filtrate, and that is why we need to use a precipitating agent, which is your tungstic acid. Now, this protein-free filtrate, or your PFF, is then titrated with a standard solution of mercuric ions or specifically your mercuric nitrate, as highlighted here, to form a soluble compound of mercuric chloride which does not dissociate to mercuric ions. And then the excess mercuric ions will then combine with your S-diphenyl carbazone to form a blue-violet colored complex. So, technically, kids, your indicator here is your S-diphenyl carbazone, which is responsible in giving or imparting a color to your sample. And syempre, mga colorimetric method kasi ito sila. Your end product here is your mercury chloride. Ito po yung end product natin, and yan po yung mini-measure natin. So, yan lang yung tatandaan nyo with regards to this one. Next, we have your mercuric thiocyanate, or also known as your white horn titration. Now here, specimen is mixed with a solution of mercuric thiocyanate, and the same with your shales and shale kids, your final product here is the formation of your mercuric chloride. So as you can see, dun sa shales and shales nyo, mercuric nitrate yung ginagamit. Dito sa Whitehorn titration, yung mercuric thiocyanate. But the final product is the same. You have your mercuric chloride. So the free thiocyanate reacts with your ferric ions present in your ferric nitrate to form a reddish-brown complex of ferric thiocyanate. So if ang indicator po kanina is your S-diphenylcarbazone, the indicator here in your white horn titration method is your ferric nitrate, which is responsible in imparting a color to your sample, which will then be measured using your spectrophotometer. So, yun lang po yung mga dapat tandaan nyo in terms of your shales and your white horn titration. So, this is the reference range for your chloride. Papaplasma or serum, the same, that is 98 to 107 millimoles per liter. For your 24-hour urine, that is 110 to 250 millimoles per day. Next, let's proceed to your magnesium. Now, magnesium is your fourth most abundant cation, and it is the second most abundant intracellular. So, meaning to say, it is next to your potassium, potassium being an intracellular ion. Now, your magnesium, around 53% of your magnesium, it is found in the bone, 46% found in your muscle and other organs and soft tissue, and less than 1% is found in your serum and erythrocytes, in which, the same with your calcium kids, it is found in these three different forms. Your magnesium can be protein bound, and as usual, primarily si albumin gyud na. It can be free or ionized, or it can be in complex with your other ions. So it can be in complex with your phosphate, with your citrate. So these are just some examples of those other ions. It can be, pwede niya maka-complex or makabind. So, syempre, same with your calcium kids, yung free or ionized form, siya yun na ang active. So these are the functions of your magnesium. It is an essential cofactor. It is involved in the transcellular ion transport. It is also involved in your neuromuscular transmission for the synthesis of your carbohydrates, proteins, lipids, and nucleic acids, and is also for the release in response to your certain hormones. So specimens that can be used for magnesium, kids, take note, na-emphasize po talaga dito non-hemolyzed. Non-hemolyzed na serum, why? Let's go back to asa makita sa magnesium, di ba? Intracellular siya na ion. So meaning to say, if your sample is hemolyzed, when we say that this is an hemolyzed sample, di ba, there is release of your magnesium, which will falsely elevate your magnesium concentration. Magnesium concentration inside your erythrocyte kids are 10 times greater than that found in your extracellular fluid. So, syempre, bawal hemolyze the sample. Lithium heparin pa rin po tayo. Bawal oxalate, EDTA, and citrate because other than it chelates your calcium, it can also bind with your magnesium. And then, 24-hour urine will always be the preferred urine sample for analysis because of a diurnal variation. So whenever you encounter the word diurnal kids, that would just refer to fluctuations or variations or fluctuations that happen during the day na kumbaga di po talaga specific or di po talaga same yung concentration ni magnesium all throughout the day. There may be cases na mas taas siya og concentration ba in the morning or mas taas siya og concentration in the evening. So that is why to consider this diurnal na variation, kaya mas pine-prefer po talaga yung 24 hours. Then of course, it must be acidified with hydrochloric to avoid precipitation. So for the determination of your magnesium, it can either be by using colorimetric methods or through your AES, which is your reference method. Now, in terms of your colorimetric methods, there are three. You have your Calmagite, your Formazan dye, and your methylthymol blue. So, very easy to remember, kids, kung ano yung name ng method. Yan yung mismong ginagamit natin and yung ini-incorporate sa mga reagents which will react with your magnesium. So, starting with your Calmagite, as you can see, magnesium will bind with your Calmagite to form a reddish-violet complex that will be red at 532 nanometers. While for your Formazan dye, it will bind with your Formazan dye and will form a colored complex. Although it was not mentioned as to what color it will produce, basta it is red at 660 nm. And then for your methylthymol blue, your magnesium will bind to this chromogen. So, of course, the chromogen that is being referred here is your methylthymol blue. And from the name itself, methylthymol blue. So, blue, yan po yung ating color na ma-produce here in this method. So, yun lang po for your magnesium. Then, your reference range for your serum, that is 0.63 to 1 millimoles per liter. Next, we have your bicarbonate. Now, bicarbonate is your second most abundant anion in the ECF, and it is a major component of your buffering system in the blood. So, of course, you already know this one in terms of your buffer system. Kasi diba, you are already done with your clinical chemistry 1, so you are already done with your arterial blood gas. Now, bicarbonate composes the largest fraction of your total carbon dioxide. Recall that total carbon dioxide is usually measured, especially in terms of your ABG, and whenever we say total carbon dioxide, it comprises your bicarbonate, your carbonic acid, and your dissolved carbon dioxide, in which, looking at this three, your bicarbonate accounts for more than 90% of your total carbon dioxide. That is why, if we want to measure bicarbonate, pwede na gyud ta mag-measure kay total carbon dioxide. Total carbon dioxide measurement, kids, is already indicative of your bicarbonate measurement. Imagine 90% si bicarbonate. So, basically, it's almost saying na it is equal to your total carbon dioxide. So that is why it is mentioned here na siya talaga yung largest fraction ng ating total carbon dioxide. So specimen to use for bicarbonate, it should be a venous serum or heparinized plasma. And kids, take note, anaerobic. Siyempre anaerobic because we are talking about carbon dioxide here. If your sample is left uncapped before analysis, carbon dioxide will escape, and what will happen is that there will be a decrease in your carbon dioxide by 6 millimoles per liter per hour, which will again directly affect the measurement of your bicarbonate. So again, whenever anaerobic collection is mentioned, always do the ETS na method of collecting your blood sample. So for the determination of your bicarbonate, ISE can be used. So here for your ISE, it uses an acid to convert all the forms of your carbon dioxide to carbon dioxide gas. And yung electrode na ginagamit natin, di ba, maalala nyo pa, yung PCO2 electrode natin, or what we call your partial pressure of carbon dioxide. Now, enzymatic method could also be used, in which we need to alkalinize our sample first to convert all forms of carbon dioxide to bicarbonate. Siyempre, if i-acidify natin siya, kids, then we would expect na yung mga carbon dioxide, what will be formed is your carbonic acid. Kasi si bicarbonate is alkaline. So, as you can see here, this is your chemical reaction. So, there are two enzymes here involved. Kindly correct this one, kids. Dapat PEP na siya. So, when we say PEP, mo lang ni siya ang ginaminan na, kids. Your phosphoenol pyruvate, and your enzyme here is your phosphoenol pyruvate carboxylate. So, phosphoenol pyruvate, with the presence of your PEP, which will catalyze PEP carboxylate, which will catalyze the formation of your oxaloacetate, in which oxaloacetate will be used for our next reaction. And in the presence of your malate dehydrogenase, so as you observe, there will be a change in the absorbance of your NADH. And thus, that change in absorbance, kids, is directly proportional to the concentration of your bicarbonate. So yun po siya for the enzymatic method. So for the reference range of your bicarbonate, so looking at carbon dioxide here, kids, 23 to 29 millimoles per liter po siya. So next we have your lactate. O, diba? As what I have mentioned, very short lang yun ng mga other electrolytes ninyo na discussion wherein there are cases na paisa-isa lang yung kanilang mga methods. So here, going back to your lactate is a byproduct of an emergency mechanism that produces a small amount of ATP when oxygen delivery is severely diminished. Kids, I already made mention about the importance of lactate during our discussion with regards to your enzyme, yung si lactate dehydrogenase. And actually, marami sa inyo yung nagkamali nito sa quiz when I mentioned na lactate is used or is utilized especially if there is a decrease in the oxygen concentration. Maraming nag-fall sa inyo and most of you changed it to a different answer. When in fact, it is true. And I guess the problem, kids, as to why you weren't able to answer it correctly, it's because yun na part it wasn't actually placed in your handout. Gimension lang yun na ako to siya. So careful yun mo ana, kids. That is the very reason why I always tell you to be at the moment, to be present mentally, to be mentally present during discussions because there are cases where you cannot actually find it in your handout. There are cases na gina-mention lang nako yun ang kaning mga important na mga kanino mga important yun na mga bagay-bagay. So, here, pyruvate is your normal end product of glucose metabolism, especially if we are looking at glycolysis. Pyruvate will be converted to lactate when there is a deficiency in your oxygen, which will then lead to an accumulation of excess NADH. So, yun na nga, even if makahatag si lactate, even if lactate could actually give us small amount of ATP, then again, dili pwede na puro na lang si lactate because there will also be an effect in our body just like your lactic acidosis, mga anak, kids, because lactate is actually can be converted to lactic acid and acidity could greatly affect our body, especially if there are changes in the pH. So, yun. Now, for lactate, kids, as much as possible, dili pwede maggamit. Tourniquet should not be used. Tourniquet should not be used because yung venous stasis natin, kids, sorry, medyo naglag, because venous stasis could actually increase your lactate levels. Then again, there are hospitals na murag wala man kayo ani na protocol na gina-emphasize. Basta ang ato lang is just to really make sure not to place tourniquet for more than a minute just to prevent any changes or any changes in the concentration of the analyte that we are trying to measure. So after sample collection, anaerobic glycolysis will occur, kids. Siyempre, even if these blood samples are already outside, na kumbaga gitanggal na nato sa atong body, still the processes inside that blood sample will still continue. Mao na siya actually ang gina-refer sa kanina statement, kids, na even after sample collection, glycolysis will still occur. Thus, make use of your heparinized plasma and it must be delivered on ice and your plasma must be separated quickly. Because since glycolysis is still ongoing, then you would expect that there will be a decrease in your lactate the more na nakatambay siya and the more na dili ninyo siya dayon ma-process. So fluoride and iodoacetate inhibit glycolysis, but the specific method directions must also be consulted. So for the determination of your lactate, pwede ta mag-enzymatic method in which we can use your lactate oxidase to produce pyruvate and hydrogen peroxide. And then this hydrogen peroxide, kids, will be used to our next chemical reaction in which the addition of your chromogen and catalyzed by peroxidase will form a colored complex. So peroxidase yung ating second na enzyme that will be used in the reaction. Then again, it was not specified as to what chromogen is incorporated in the testing. Basta colorimetric method pa rin ito, kids. There will be formation of colored complex or colored dyes in which that will be measured using your spectrophotometer. So yun po for your lactate. And then this is the reference range depending on what type of sample you are using. So kung enzymatic ba siya or katong inyuhang colorimetric. Kasi actually kids, I guess it was not actually mentioned by Bishop really. Then again, there are cases manggod daw na pwede kanilang na reaction and then proceed na dayon with measuring or pwede na to siya ipadayon to the second na reaction. So kaya siguro may naka-emphasize dito na enzymatic or colorimetric. Sige, so that is all of your other electrolytes, kids. Then again, let me emphasize this one with regards to your anion gap. So this will be the last portion of our discussion here in our lesson 7, all about your anion gap. Now, anion gap, kids, is useful in indicating an increase in one or more of the unmeasured anions in the serum, and as a form of quality control for the analyzer used to measure electrolytes. Now, this is the reference range of your anion gap. It is around 10 to 20 millimoles per liter. Diba remember that what is routinely measured the mga electrolytes involves your sodium, your potassium, your chloride, and even your bicarbonate. So how about your other anions, kids? So yan yung nilulook into sa anion gap nyo. Now, anion gap is the concentration difference between your commonly measured cations, which are your sodium and potassium, and your commonly measured anions, which is your chloride and your bicarbonate. And thus, there are actually two formulas that can be used in order to measure an ion gap. Pwede po ito, sodium minus your chloride plus bicarbonate. Or if we would include potassium, then sodium plus potassium minus chloride plus your bicarbonate. So to further explain an ion gap, kids, actually na ako i-place na video which would actually help me explain this more. So para mas masabtan siya, let us watch this video.
Hey everyone, hope everyone's doing well. So today we're going to discuss anion gap. So if you're somebody who hasn't watched my arterial blood gas video, please click on the link in the description box, watch that video and come right back. So let's dive into the topic of anion gap. It is basically a very important diagnostic tool while looking at metabolic acidosis. It took me a while to get a hang of this concept, but I have simplified it as much as possible. It's basically the level of cations, which are the positively charged ions, versus anions, which are the negatively charged ions in the serum. Our body, it follows the law of electroneutrality. That means in all body compartments, the number of anions and cations should be equal. So this is what the equation should look like. The major measured cations are sodium and potassium, whereas the anions measured by this equation is chloride and bicarbonate. So if the serum is actually neutral, anion gap should be neutral, following the law of electroneutrality. So why isn't it neutral? Why isn't it zero? It's because while sodium and potassium account for the majority of the positive charge, we're ignoring a number of unmeasured anions like phosphate, sulfate, the anion component of organic acids, and also negatively charged plasma proteins like albumin from this equation. So if the gap increases, this anion, so-called anion gap increases, it means that there are a greater number of these unmeasured anions in the serum. This is what accounts for the anion gap. Anion gap is nothing but the unmeasured anions which are not included in this equation. So what is the normal anion gap? Let's bring the formula back. Sodium plus potassium equals to chloride plus bicarbonate. But sometimes, most labs, only the sodium value is taken because potassium is proportionately less in the serum. So this is what the formula should look like. Sodium minus chloride plus bicarb equals to 0. If you put in the normal values, this is what the answer will be. It will be 12 milliequivalents per liter. Putting it into a range, which is plus minus 4, it should be 8 to 16. So 8 to 16 milliequivalents per liter is the normal serum anion gap. This may vary according to labs and according to the equation, whether it includes sodium and potassium or just the sodium component. So how is it useful in metabolic acidosis? Acidosis can be classified as high anion gap or normal anion gap. So this can be helpful in correctly identifying the cause of acidosis. So while thinking high anion gap, think increase in organic acids in the bloodstream. So some examples of organic acids are lactic acids, keto acids, formic acids, which is a metabolite of methanol, and oxalic acid, which is a metabolite of ethylene glycol. So conditions in which these are increased are lactic acidosis, for example in salicylate overdose or shock, ketoacidosis in DKA, formic acid accumulation in methanol poisoning, and oxalic acid accumulation in ethylene glycol poisoning. Let's take lactic acidosis as an example. In solution, it's present as two entities. It's present as lactate and H plus ion. Lactate is the anion component and H plus ion is the cation component. In this, lactate is not accounted for in the anion gap calculation. So it basically belongs in the unmeasured anions. In lactic acidosis, the H plus component is buffered by the bicarbonate. So this is what the equation looks like after buffering. I'm sure all of you are familiar with this equation. So in the buffering process, the bicarb is decreased in the serum, but the serum remains electroneutral because although there is decrease in bicarb, there is more lactate accounting for the anion component of it. And this lactate component is not measured in the anion gap calculation. So this appears as a high anion gap in the solution. So what about normal anion gap acidosis? Let's look at the most common causes. The most common cause is diarrhea, and another important cause is RTA or renal tubular acidosis. There are many types of RTA which is beyond the scope of this video. But the most common type is where bicarbonate reabsorption in the distal convoluted tubule is impaired. So in diarrhea, what really happens? In diarrhea, the bicarbonate is lost. So bringing back the equation, if in this equation the bicarb is lost, to form carbonic acid, we need bicarb to buffer the H+. So here, due to its loss, the serum is acidotic. In these cases where the bicarb is lost, the kidney compensates it by reabsorbing increased amount of chloride. So this is a normal anion gap acidosis because the loss of bicarbonate is compensated by chloride and not by some other unmeasured anion. Both bicarbonate and chloride are accounted for in our anion gap equation. So in this case, it's also called a hyperchloremic acidosis because the loss of bicarb is compensated by an increased amount of chloride. In this case, the anion gap remains normal and the serum remains electroneutral. You may ask why this is not the case in vomiting. In vomiting, both bicarbonate and H plus ion is lost, not just bicarbonate. Similarly, in renal tubular acidosis, bicarbonate is lost, so chloride is increasingly reabsorbed to compensate. So, even if all of that information went over your head, just remember that high anion gap acidosis means increased organic acid, and normal anion gap acidosis means decreased bicarbonate, which is compensated by increased chloride. And a normal anion gap is 8 to 16. So, here's an example for you to solve. I will give you 10 seconds to solve this one. Your time starts now. So here the anion gap is 10, which is in the normal range. So coming to the causes, I'm just gonna put a couple of slides which you guys can screenshot and put it up on your wall or just memorize it a bit later. But these are the very famous mnemonics which are present everywhere. So yep, that brings us to the end of this video.
Alright. So, di ba kids, ang ganda-ganda ng pagka-explain niya and she even presented your significance, your clinical significance here about your anion gap. And it actually already covers your electrolytes, your other electrolytes. Na-mention si bicarbonate, na-mention si chloride, na-mention si lactate. So that is why I really incorporated this video because this could really explain, murag siya na ang naka-explain yung tarong kumbaga sa inyuhang anion gap and how important it is. So, yun po yung anion gap nyo and just make sure to remember the formula and the reason behind why there are two formulas presented. The other one is without considering your potassium. And then, ito po yung mga causes and you have your mnemonics. So that actually ends our discussion here regarding your lesson 7 and I hope na nasabtan siya if in case na ako yung mga certain points or certain things na wala na explain og tarong kids so feel free to really message me kay basig wala lang yun na ako siya na explain og tarong. So thank you for listening kids and I hope na nakasubaybay ay nakumbaga na take note og tarong yun ang kato mga atong gipang discuss karon. So again, thank you so much.